Hi, Ms. Cheryl.
Hi.
I'm Dr. Lecoq. Nice to meet you. We're going to be doing our exam today. And I wanted to ask if you had any questions before we began.
No,
Nice to meet you.
you also.
Thank you. So the first thing, I'm going to take a look at how you're feeling today. You look like you're having a good day.
Pretty good today.
Excellent. I'm also looking at her eyes, at her mouth, at her facial symmetries, the function of her cranial nerves as I go through this. The first thing that we'll do now is to check for pupillary response. And although we can use a pen light for this, the otoscope is always there. So I'm going to ask her to look at my nose, and then I'm going to come from the side, shine it on this eye for the direct response, and then I'm going to shine it again on this eye while watching the other pupil for the consensual response as I flash it across. And we'll reverse that too. So again, look at my nose, I'll come in from the side, I watch that pupil constrict, and then I flash the other one to make sure it's the same side. Now we'll go through the lymph node exam, actually the oral exam, and I'll get the tongue depressor out of the package, and again, use the otoscope. Now, Ms. Cheryl, if you could hold on to that, I'll make sure it doesn't snap back on you.
Okay.
If you could open up big and wide for me, good job. And say, please. Good job. If you could bring the tongue back, I'm going to bring the tongue depressor in from the side, and I'm going to make sure that I look down deep so I can see way down and actually see the bottom of the gum. And the same up here. I'll ask you to look up a little bit. There we go. And that helps me to see all the way up in there, but I'm seeing the very base of that. Now I can look under her tongue if she tips her chin downward. There you go, and open up big and wide. I'm looking straight down, good. And now if you can put your tongue straight out, I'll have you say, ah. But you notice that when you use the tongue depressor, you don't always get the best view of the back of the throat. But this is important for visualizing the other tissues. So I will dispose of that. And now we will do our cervical lymph node palpation. I'll even turn the lights back on. When we do the cervical lymph node palpation, it's better to think about a path as opposed to trying to remember 10 things in a row. And I'll start with the preauricular nodes. These are enlarged sometimes with viral eye infections. You'll notice that my fingers kind of bubble, and I'm putting some pressure on there. I'm also going to go to the postauricular nodes, which are over the mastoid bone. And again, I say bubbling, meaning I'm wiggling my fingers around because it makes it easier to detect those rubbery lymph nodes. I shouldn't feel any though, and I don't. I'm going to feel at the occipital nodes right at the rim of the skull. Then I'll bring my hands forward to the sternocleidomastoid muscle, which divides anterior from posterior. Again, I'm pushing into the valley with hooked fingers. Here I break off the path to come up to do the jugular node or tonsillar node, either name works, and the mandibular nodes, submandibular nodes, submental nodes. Now I return back to the anterior part of the cervical chain in front of the sternocleidomastoid, bubbling those fingers on both sides. Then the deep cervical nodes are actually inside the sternocleidomastoid muscle. So I'm going to ask the patient to turn her head toward her left, and that puts the slack on this muscle and makes it easier to palpate that one, and the head the other way. And I can get down into that sternocleidomastoid and feel for that lymph node that's actually inside the muscle. Next, I'll do the supraclavicular nodes, which are above the clavicle, as the name implies, and the infraclavicular, which is below the clavicle. And again, I don't feel any lymph nodes. So that's a normal lymph node exam. For the heart exam, I'm going to ask the patient to lower the gown when you're ready and make sure that the stethoscope diaphragm is on. And we're going to palpate those landmarks. So suprasternal notch, there's the sternal angle, which is a shallow valley that goes across right here, goes to the second rib. And below that second rib is the second intercostal space. That's the first place we'll listen. And that's the aortic area. On the other side, this is the pulmonic area. Same second intercostal space, but on the left, we have Erb's point, which is where we listen for aortic insufficiency. And space 3, 4, and 5 is her tricuspid valve. And then I'm going to ask the patient to lift her breast so that I can listen right over the mitral valve. The mitral valve is generally in the midclavicular line, just below the breast. And sometimes you can get a bit of the tricuspid area down here. I listened up here, but because she has a bra on, I might want to check both areas. And then the final step is to activate the bell and listen once again over that mitral area. If you could lift one last time. And I hear a good S1, and all I'm really listening for is silence. If I hear silence, I'm about done. Because that means there's nothing else there other than S1 and S2. Okay. Now I'll listen to the back. And key thing in listening to the back is you want to make sure that you're listening symmetrically. You always start above the scapula. Big breath in and out. Good. Good. Yeah. This will be a somewhat abbreviated exam. On the full exam, you'll be listening to 5 pairs down the middle. Make sure you listen until the end of expiration, or else you might miss wheezes. And then finally, and I'm listening through clothing only because that's required in PDL, but otherwise we wouldn't listen through clothing over this area. I'm also listening over the last ribs. You want to make sure and listen at the base of the lungs. Last area in the front is that of the right middle lobe. And basically, if you could visualize the patient grabbing her armpit, that'd be the area of the right middle lobe. And this is important because sometimes people inhale food, and because of the positioning of the right mainstem bronchus, it lands right there. And everything sounds nice and normal that way too. So now we'll have the patient lie back. And always remember to extend the leg holder. And if I could ask you to lower the waistband. Yes, there we go. So the first thing is to inspect. You see a little bit of hyperpigmentation down the middle, which is normal. You can look for surgical scars, melanomas, other skin lesions. Here's a cherry hemangioma, which is very normal. It's just a little red spot on the abdominal wall. Now, ordinarily, auscultation is last, but in the abdomen, that's the step that occurs right after inspection. And we're going to listen in all 4 quadrants. And basically, you're listening for the presence or absence of bowel sounds. And once you hear bowel sounds, that's the most important thing. In order to say there are no bowel sounds, you have to wait 2 to 3 minutes before declaring that. And that's a long time. Okay, but I hear nice normal bowel sounds. There's some other noises you'll learn about in the future from big vessels in the abdomen, but we're not going to check those for today. And we're going to do percussion next. We're going to percuss the liver. And I'm going to get my finger under the breast, right at the border of the breast, and roll my finger upward. And it's nice and hollow. Come down a space. Okay. Well, Miss Cheryl's the exception because she's hollow all the way down.
Oh, sorry.
Oh, no, it's not your fault. And some people will be that way. Some people say because there might be a loop of bowel between the liver and the abdominal wall, but ordinarily you'll get a nice hollow note, and then the next space it'll be dull, and that marks the dome of the liver. The dullness comes because there's a watery, fleshy mass behind the percussing finger, and up higher than that, it's lung. That's why it's hollow there, and then it'll change. So if we find the upper border, then we come up from the bottom to percuss out. And again, she's pretty hollow. This is why I don't let people percuss my head. On the other side, we're going to percuss the spleen, and there are a couple of different ways to do this, but I like this as a shortcut. We're going to go in the anterior axillary line in the last rib space and have her take a deep breath and out. And what we're doing here is seeing if the spleen comes down under my finger. If the spleen were enlarged and came down under my finger, that note would change from hollow again to dull, just like the liver did on the other side. With respiration, the diaphragm comes down, pushes that spleen underneath my finger, and it'll sound hollow. We're also going to check for fluid in the abdomen. And think about it. If I put a quart of milk into her abdomen, where's it going to go? There. So we're looking for dullness down here. So we can start here. And you want to percuss nice and low. And it stays hollow, which is the important part. If there were fluid in there, which we call ascites, that would not be hollow all the way down to the bottom. And finally, we'll palpate the abdomen, meaning to feel. And you always use your whole hand on the abdomen, and you always make sure your hands are warm. Thankfully, it's July in Ohio, so we don't have to worry too much. So I'm going to gently put my hand, I'm going to percuss lightly, not too deep, just for any surface masses. A fun trick is that if you feel a mass, you can have the patient lift her neck or tense her abdomen muscles, and if there's a mass only in the superficial layer, you'll still feel it when the abdominal muscle is tense, but if not, it means it's behind the abdominal muscle, which is usually more worrisome. And then we're going to be palpating a little more deeply for any lumps or bumps. And then we do special two-handed palpation for the liver and spleen. The hand comes behind the fleshy part, not the ribs, but the fleshy part to pull skin upward. And then I'm going to see if I can run my hand and run into a liver edge. Alternatively, you can hold your hand in a spot and ask the patient to breathe. And if there were a liver edge, you'd feel it bump your hand. I learned this way. This is the way I like to teach it too. And I try to come up until I'm finally right below the rib. And I don't feel anything. So maybe the liver edge is up here waiting to come down and bump my finger with a deep breath. So we'll ask the patient to take a deep breath. Very good. And I don't feel anything coming down. So same on the other side with the spleen. I'm going to lift up on the fleshy skin part. And I'm going to try and run the edge of this index finger. Even though all these fingers are on, this index finger is doing all the feeling. I'm going to angle it inward. And you notice how deep I am. I have to be beneath these ribs because that's where the spleen's going to come out. If you're waiting up here, that spleen will never hit you. So you have to be in here. And again, picking up on the skin gives me a little extra movement. I don't feel a spleen edge, so let's see if it's there with a deep breath. And nothing comes down and hits my finger. So I'm pretty confident that she doesn't have enlargement of the spleen or the liver. And the final part you can cover up if you like. And the final part is inspecting the extremities. We'll have you sit up, Miss Cheryl. There we go. I just want to congratulate you on sitting up.
Maybe take my shoes off.
Yeah, thanks. We never examine through clothing. And feet are particularly important because there can be all kinds of things. In fact, Nurse Raber found a toe from a patient when it took off the sock. So there's a war story for you. So the first thing is to inspect. I don't see any discoloration. I don't see any malformations. I do see a scar, which probably represents a bunionectomy, and maybe a very slight sock line that I wouldn't necessarily consider abnormal. But we are looking for edema or swelling at the feet. So I'm looking for any puffiness back here. This is the inspection part. On the soles of the feet, we're looking for any foreign bodies because she may have stepped on a thumbtack or something else. And if she had a bad nerve problem, like you might find in a diabetic who's advanced, they can have things stuck in their feet and not know it. And they can go on to get infected. But she has beautiful feet. Next, we're going to check for the posterior tibial pulse on this side at about 4 o'clock. If this is 12 on the clock, you're going to feel around the back, as the name implies, posterior tibial pulse. And she has a good, strong pulse there. And then dorsalis pedis, which is just inside the extensor hallucis longus tendon. If you can lift for me against there we go. See that nice tendon? You feel halfway on the lateral side And she has another good strong pulse there. Also, the pulse check with the posterior tibial, this is the first place edema or swelling will show. So if I push in, moderate pressure, probably a couple pounds, I'm going to see if there's any dent left when I rub over it, and there's not. And sometimes you can get swelling on one side. So we're going to do the same thing on this side. And again, she has a good pulse. I'm not seeing any swelling, and I will check the dorsalis pedis pulse as well. And she did great. Thank you, Ms. Cheryl. You look terrific.
Well, thank you.